And then also John Shin was kind enough to tag along tonight and moderate. And obviously he is a wealth of knowledge, and we were lucky enough to have him come and join the pen practice. We're also joined by three of our fellows. We have Johannes, who's going to start with a nice overview in regards to some of the literature and some of the findings that we have here at Penn in relation to PJK. And then we're also joined by two of our orthopedic fellows, Phil and Poria, and they're going to present some cases. So a robust agenda to get through tonight, and obviously we'll keep our eyes on the chat box, and certainly we'll be grilling some of the panelists to get their thoughts. So if you don't mind, Johannes, please take it away.
Yeah. So as Dr. Casper said, I'm Johannes, one of the PGY6 neurosurgery residents at Penn, currently doing my infolded complex spine fellowship this year. I just wanted to say thanks for the opportunity to present. I've actually been using the Seattle Science Foundation videos as an educational resource since I was a med student, so it's great to be here today and get to contribute. So proximal junctional kyphosis and failure are two common phenomena following multi-level thoracolumbar fusion for adult spinal deformity that result from increased stress at the junction of the fused and mobile spine. I'll be going into the background on PJF risk factors prior to going into the case-based discussions. So the definition of PJK is pretty well accepted in the literature and is defined as an increase in the proximal junctional angle by 10 degrees from preoperative values. The proximal junctional angle, or the PJA, is formed by the angle between the inferior end plate of the UIV and the superior end plate of the UIV plus 2. PJK has a high incidence following correction of adult spinal deformity and is often asymptomatic, poorly correlating with clinical outcomes, and many times is just a radiographic phenomena. But on the other hand, proximal junctional failure may be a more severe outcome along the PJK spectrum, or could be a separate clinical entity. Unlike PJK, the definitions in the literature are more varied, but a unifying theme across the PJF definitions is that there's either a substantial increase in the proximal junctional angle, bony failure surrounding the proximal junction, or some sort of disco-ligamentous instability. This leads to high rates of morbidity and reoperation when compared to PJK. And the literature surrounding PJK and PJF is pretty extensive, so right now we're just going to focus on PJF. So multiple studies since the early 2000s have identified common risk factors for development of PJF. Some of these include patients with higher BMIs placing greater loads on the spinal column, older age, poor bone quality through comorbidities such as osteoporosis, and large sagittal corrections as measured through changes in a patient's sagittal vertical axis or lumbar lordosis. Furthermore, subtypes of failure at the proximal junction have also been shown to vary based on the selection of the upper instrumented vertebra. So when it's dichotomized into the upper thoracic versus lower thoracic, patients may present with a different PJF subtype. But overall, it's important to note that the different definitions of PJF along the PJK-PJF spectrum, different surgical constructs such as ending your instrumentation in the pelvis, and surgical indications creates a lot of heterogeneity in the PJF literature, and this leads to a lot of varied conclusions across studies. In recent years, emerging risk factors have focused on markers of health at the proximal junction. These include Hounsfield unit measurements on CTs, vertebral bone quality on MRIs, and sarcopenia on MRIs. So Hounsfield units are measured on the preoperative CT. You basically draw regions of interest on the sagittal and axial planes of the upper instrumented vertebra. This reflects bone mineral density, which correlates well with osteoporosis. So prior studies have shown that cutoff values somewhere in the low 100s to mid 100s is predictive of PJF development. Vertebral bone quality is measured as a ratio of the T1 signal intensity between the L1 and L4 vertebral bodies, and that's divided by the signal intensity of the cerebrospinal fluid. This is thought to reflect fatty infiltration of bone, so that a higher fatty content in the bone may lead to more PJF, and some studies have shown evidence of this. Then lastly, sarcopenia is a risk factor on MRI that measures fatty infiltration of the paraspinal musculature. And then this is thought to serve as a marker of a weakened extensor complex. You can imagine this could increase the rates of PJF, again, another risk factor at the proximal junction. So overall, the combination of these new risk factors helps in patient counseling, optimization, and preoperative surgical planning. Overall, they may reflect just that a patient is increasingly frail, which has also been shown to be a risk factor for PJF. So given that several PJF risk factors are localized at the proximal junction, Several strategies have been employed to either strengthen the proximal junction or create a gradual transition zone from rigid spine to mobile spine. So both UIV strengthening through cement augmentation and semi-rigid instrumentation through the use of hooks have shown mixed results in the literature. Reconstitution of the posterior tension band through Merceline tape is a newer strategy that shows promise. And it's nice because you can modify the tension of the Merceline tape. And then additional strategies include meticulous exposure around the UIV as to not disrupt the soft tissues or the facet capsules, as well as percutaneous instrumentation around the UIV. So PJF clearly is multifactorial in nature, and recent evidence has shown that combinatorial strategies, such as avoiding overcorrection while using some form of prophylactic measure, such as hooks, cement, or Merceline tape, may be most effective at reducing PJF incidence. So given the severe consequences of PJF and the need for additional research, I created a database of our deformity population at Penn to study PJF risk factors as one of my research projects during my research year. So we've recently retrospectively studied PJF in a cohort of 199 patients that underwent correction of adult spinal deformity between the years of 2013 and 2021. All of our constructs had the UIV somewhere between T3 and T11, and then all instrumentation ended in the pelvis. We extracted a large set of variables that are both intrinsic to the patient and then specific to the surgery they had. Some patient intrinsic risk factors include, the standard demographic data, as well as comorbidities such as BMI and osteoporosis. And then surgery-specific risk factors that we looked at include variables such as the degree of sagittal correction on pre- and post-operative scoliosis x-rays, the angle of the screw at the upper instrumented vertebra, osteotomy techniques, and then PJF prophylaxis at the upper instrumented vertebra. We looked at cement and hooks. We didn't have any patients that had Merceline tape used at the UIV +1. And then in order to mitigate the confounding effects of retrospective study designs, we balanced patient characteristics between the PJF and the no PJF groups. To do this, we generated propensity scores using variables age, gender, BMI, race, and ASA status. And then we used inverse probability weighted analysis to study the effects of the patient intrinsic and surgery-specific risk factors on the outcome of interest, which was PJF. My slides froze. There we go. Our average follow-up was 2 years, ranging from 9 months to 6 years. PJF developed in 30 of 199 patients, leading to an incidence of 15.1%, which is on par with the prior studies that have looked at PJF incidence. And the majority of cases that occurred, they occurred within the first year after their index surgery, which you can see on this Kaplan-Meier curve. 60% of patients that developed PJF had a large magnitude of kyphosis at the proximal junction. So that was a PJA of greater than 20 degrees. 30% had either fractures at the UIV or the UIV +1. And then 20% had some evidence of disco-ligamentous instability. So overall, this adds up to more than 100%, but this is because some patients presented with more than one PJF subtype. The predominant symptom that patients had was midline back pain around the level of the UIV. And then a subset even presented with some degree of spinal cord injury. Our rate of reoperation was around 50%, requiring extension of fusion rosterally. And patients with PJF had lower Hounsfield units at the UAV based on preoperative CT scans. They also were more likely to have a diagnosis of osteoporosis, but this was not seen after inverse probability weighted analysis, as sex was a covariate that we used to control for baseline characteristics. We also found that cranially directed screws at the upper instrumented vertebra were associated with PJF. And then we're actually, performing a more in-depth study looking at this variable to see how the angle of the screw at the UIV can impact PJF development. Hooks were used in 40% of our patient cohort, and then cement was used in 10% of patients, but neither prophylactic had an effect on PJF development. And then lastly, we looked at whether the magnitude of correction in the sagittal plane through sagittal vertebral axis as well as lumbar lordosis affected PJF rates, and we found that this did not impact development of PJF. In fact, it actually increased the risk of PJK in our cohort, but for the purposes of time, I'm not presenting the PJK data of the study. So that was just, a background on PJF, some of the data that we have at Penn. So I just wanted to leave some time for questions before moving on to the first case.
Yeah, very, very well said, Johannes. And I think, that displays kind of the complex nature of this problem. Obviously, this is a broad strokes question, and the issue with these deformity patients is the heterogeneity, whether it's in curve type or patient factors. But I'd love to get Jack, Scott, John, please, pearls for this. If you're kind of approaching let's just call it a T10 to pelvis type case, and obviously that's exceedingly variable, but are there any tricks or things that you routinely do, whether it be some of these tethers or preservation of soft tissue envelope, moving in the direction of MIS surgery to really preserve some of those ligamentous and muscle layers?
Well, you totally picked some of the wrong faculty to answer those questions.
Maybe I'll pick
I
on
think Jack
John.
will admit to that. But I do have a question because of all the multifactorial things, you didn't mention any data that either you guys have or you find in the literature on upper instrumented vertebrae. Is there risk factors to where you end the construct upper?
Yes, so in our study, we did look at, ending your fusion in the upper thoracic spine. So, T1 to 6 versus lower thoracic, which we defined as, T7 to 11. That there was no significant, change in the rates of PJF in our cohort. I know in the literature, there are studies that have shown ending your construct in the upper thoracic spine is more likely to give you ligamentous PJF, where you have progressive kyphosis. But if you're ending in the lower thoracic spine, studies have shown that you're more likely to have bony PJF with a fracture at the UIV. But in our study, I didn't show the data. It didn't show any difference.
Okay.
Johannes, that was a really great overview. Dave, I think to answer your question, I've always found the proximal tethers to be quite effective. I like incorporating that. I think we all like to preserve that, soft tissue envelope, like you said, not disrupt the proximal facet joints. But I do like the tethers. The one thing, though, I think that we need to figure out in deformity is really the tension, the ideal tension there, though, because I think it's one of those things where you can keep dialing it in. And you can break through the spinous processes or however you're looping these tethers around. And so that is something I'm curious, what the literature will bear out, what further studies will show. So,
Excellent.
Johannes, really, really nice job. Johannes is a meticulous researcher, and he took a keen interest in this topic. To me, one of the most interesting things of what he found from our data is that we tend to think of PJF as a progressive form of PJK. And based on this, you almost wonder if it's two different pathologies. And, as Dave alluded, it's the heterogeneity that I think makes researching this very difficult. For example, anything over 5 levels and you anchor to the pelvis, we sort of call deformity. But, the reality is when many of those operations you don't necessarily need to do because you might be doing it because of coronal or sagittal imbalance, or maybe you're doing an in situ fusion for whatever reason, T10 to whatever. So I think it becomes really challenging. When you restore lordosis, a lot of times those patients make their thoracic spine hypokyphotic. So it's very natural that some kyphosis returns to the thoracic spine. In fact, that might be a good thing. So PJK might not always, many times it's not a pathologic entity, whereas PJF is. I thought his study was real interesting, and it definitely points to sort of local factors at that T10 junction, bone quality, the angle of your screw, any sort of mitigating things. I think the jury's a little bit out on that. I think the data, when you look at everything, probably the tethers seems to be holding the best so far, and like John said, some more sophisticated instrumentation and an ideal tension there would be nice to know. I've been incorporating that probably the last year a lot more as well.
And maybe one more quick question for Dr. Colson. Can you comment on this idea of age-matched correction? Obviously, we have some numbers in mind when we're eyeing up patients, but does that change whether it has to do with bone quality, as Johannes mentioned, or whether it's patient's age or habitus or anything like that?
Yeah, it's a great point, Dave. I think traditionally greater than 5 centimeters, we think of that as a pathologic SVA. Now we know, certain septuagenarians, octogenarians probably want to live around 7.5 centimeters or so. And what we really know now is it's probably way more complicated than that. I know me personally, for longer segment constructs, I've been employing some of these patient-specific rods because I think to Ali's point, predicting the flexibility and the postoperative kyphosis of the thoracic spine in the uninstrumented portion, I think is just as important as how you dial in your correction in your instrumented portion. And I think some of these AI-driven databases that are coming around the corner now can be extraordinarily helpful to develop kind of predictive algorithms about how the rod should be bent to kind of flow into a natural thoracic kyphosis. So I think we're learning more and more every year.
That's great. Johannes, do you mind transitioning us into the first case, please?
Yep, we'll do. Okay, so for case one, we had a 65-year-old overweight female with a history of osteopenia that presented for severe neck pain, worsened posture, and prominence of her hardware 4 years after deformity correction. Her index surgery was for severe back pain and poor posture in the setting of 40-degree thoracolumbar scoliosis spanning from T12 to L4. She underwent a staged lateral and posterior approach through L2-3, L3-4 lateral lumbar interbody fusion, followed by L1-4 posterior column osteotomies, and then T4 to pelvis fusion. She had good clinical and radiographic results following her index surgery before developing these new symptoms. So here you can see her preoperative AP scoliosis x-ray, a 40-degree curvature. Postoperatively, that curve was reduced to around 10 degrees. So surveillance scoliosis x-rays from short interval post-op films to 4 years post-op show progressive kyphosis at the proximal junction. So here's our preoperative scoliosis sagittal x-ray, 1 week immediate post-op films, delayed in the sense of 4 months, and then 4 years post-op. So you can see at the proximal junction, she's starting to hunch over. Then here's a closer look at the proximal junction. The patient's T1 slope significantly increased with a reciprocal compensatory increase in her cervical lordosis. And then a CT thoracic at this time showed bilateral loosening of the top 3 pedicle screws with near complete pullout of the screws at the UIV. She also had an MRI at this time that didn't show any cord compression, and the patient didn't have any signs of myelopathy. So given progression for PJF, she underwent surgical revision. Here's a picture of the setup that we like to use for correction of cervical thoracic kyphosis using 2 Gardner-Wells tongs, as well as biplanar traction. The patient underwent removal of her loosened instrumentation at T4 and T5. She was instrumented from C4 to T3. And then to correct her kyphosis, she underwent T3-4, T4-5 posterior column osteotomies with assistance from reduction towers at T2 and T3. And we also used the biplanar traction. And then lastly, a supplementary rod was placed at the level of the PCO to give additional support.
Johannes, do you mind going back to her x-rays that kind of show the progression of her PJK?
Yeah.
Ali, thoughts on this? Obviously 4 years out is a little bit interesting from this perspective, but just maybe your thoughts on the evolution in your case here.
Yeah, this is unusual. This lady did very well, and then you'll see she's almost lost to follow-up. I didn't see her back until 4 years ago, and her main issue was that she felt the tips of her rods. Looking at it in hindsight, talk about probably a little bit of overcorrection in the sagittal plane. I didn't do anything mitigating here. I had sort of gone through a dark phase with hooks. I hadn't started using Merceline tape. So it was just a rigid to flexible spine kind of transition. I think I was using stainless steel rods. I prefer titanium now. Maybe that would have helped. I think and then weak bone, kind of an overweight lady. So she was a bit of a setup in hindsight.
And Dr. Shin, maybe you can, if you advance to the CT scan, maybe Can you walk us through some of your thought process as you're kind of looking at this patient in your clinic and
Yeah.
comes back and has
So
this?
for this, I mean, it's clear what's going on. It's clear she needs to be extended to the cervical spine. From my perspective, I don't always think it's necessary. When we think of, deformity in the cervical spine, people frequently think of C2. I don't think it's necessary to go to C2 in a nicely lordotic spine personally. So I extend usually to C3 or C4. The toughest thing, like as with any deformity, really is trying to understand how flexible this is going to be. I have a tougher time in the upper thoracic kyphoses than I do in the lumbar spine, understanding preoperatively how much I can get relatively passively and whether I need to do a 3-column osteotomy or whether posterior columns are going to be enough. So when I see this, I usually almost always prepare to do a 3-column PSO in the upper thoracic spine, usually at the top level of instrumentation. Way we start that is we do our laminectomy, we do a posterior column osteotomy above and below. That's how we start most of our PSOs. I'll remove the ribs. And I'd say about half the time that's sufficient to loosen the spine and get a satisfactory correction, as it was in this case, especially with the traction. We'll use reduction towers, we'll compress. If it's not enough, we're prepared to go anterior. We've done half of the work anyway. So we're prepared to do that. I usually, like I said, I have a tough time gauging that. If anyone has any tips on it preoperatively, I'd be curious, but these are usually booked for possible PSO, but the osteotomies they'll get. And this lady, I didn't need to. I thought we got a good enough correction. Obviously, I'd prefer not to do a PSO where there's spinal cord if I can avoid it.
Hey, Dave, looks like we had a hand raised by Dr. Chapman.
Thanks, guys. I just finished a cervical thoracic osteotomy. But when you look at this is beautifully done. And yes, the self-criticism of you probably overcorrected a little bit may or may not account. I see this, if you go back just a wee bit, I see this as a myopathy, a muscle failure. If you just look at this swan neck, this kind of a sagging forward of a shoulder girdle, I can literally picture this patient in front of me. I have them many times. Their shoulders fall forwards. They have no extensor posture, extensor awareness or anything like that. And this cannot win. So you did a beautiful job, and no band, no rubber band, no whatever, no hooks can prevent this. If the patients cannot muster the self-awareness and avoidance, I just wanted you to not put too much sand on your head there. This is nicely done. And this is a more global problem, sarcopenia or lack of engagement. So I'm curious how you fix this, but I just want to throw a
Thank you. That's nice of you to
kudos your way.
say. It makes me feel better.
Can I ask the grumpy old man a question? Are we chasing, natural history of, failing protoplasm, muscle and bone, or are we following iatrogenic hypomobility of the entire spine from thoracic down, and a patient who's trying to compensate and is losing the biomechanical battle? So in other words, I'm saying, if you hadn't operated on this lady, would she be having this issue now without hardware about to poke through her skin?
I think she would. And I wish that we could, I know this sounds silly to say, but probably a lot of people, if you could do a C2 to pelvis on kyphotic patients, that's probably the real treatment for it. And we do, obviously that's an enormous operation in one setting. No one would do that. Sounds ludicrous, but probably that's the treatment for this disease. We end up going to T10, and then, many of them, that's what they end up doing in fragments. But, I think that's a little bit of the issue. I think it is just the natural history, and we just do it in pieces.
I think Jens makes such a great point about there's something globally going on here. And I think, like in a lot of cases, and something like, I think we're starting to think about more like frailty, these concepts of sarcopenia, and getting away from just using BMI as a metric for, their fitness for surgery. Because I think if you look at that pre-op sort of full spine x-ray, if you look at the soft tissue density, right? And you sort of take your eyes off where the screws are and where the spine is, I mean, clearly there's a lot going on there that we don't understand with regards to body composition and, their muscle nature and their preoperative, their gait, their functional capacity that we don't assess dynamically. And so I'm just throwing it out there because I know those are the things that I've been really interested in recently and want to find people to help study that, because I think that's really going to help us identify maybe predictors of PJK, PJF.
Yeah, John, I agree with you. I mean, we have Rusali for thoracolumbar kind of scoliosis deformity, but what about cervical lordosis? Especially in the elderly, cervical hyperlordosis. That plays a huge role here. And again, nature versus nurture. I think a lot of this deformity is happening one way or another. She just needed this thoracolumbar fusion, in the interval time period, and then the cervical thoracic junction reacts this way. So, hey, Ollie, real quick question. When you're doing these complex deformities, what are you doing intraoperatively to try to gauge some of these kind of sagittal coronal parameters? Particularly sagittal in this case, to try to obviously mitigate risk for PJK, things like that.
Johannes, do you mind just advancing to the final x-rays while Ali speaks on this?
Dave, could you, Amrit, can you ask that again, please? I missed the
Yeah,
question.
so what intraoperative techniques are you utilizing here? Obviously, fantastic revision correction here.
Yeah,
just to gauge about where you dialed in the patient from a sagittal alignment standpoint.
yeah. It's difficult. I mean, we have a nice flat plate that can get me about 50% of the spine. It's really humbling, still how shocking things are when you really don't know until they stand up post-operatively, and you really don't know until 3 months post-operatively. And we wrote a paper as well, just comparing the immediate post-operative X-ray and comparing it to a 3-month post-operative X-ray. There's very substantial difference. In a lady like this, you'd think, how's that possible? It is, and there's significant differences in their SVAs. I look at the segment that I focus on the segment I'm trying to correct, and I try to figure out what's the end product of that segment. That's about all I can do, and kind of eyeball it, I guess. I know John wants to bring an intraoperative EOS or close to, isn't there some kind of technology that you're interested to bring? I'd love that. I'd absolutely love that.
Yeah, I honestly thought it was a game changer when I was at the MGH.
Yeah.
This 3-foot interop digital flat plate, and you could basically, what you're looking at in this slide, like we could visualize. And so I think especially not just, I mean, we're always fixated on sagittal plane, but I also think for coronal, I think how many times do you get these films, Amrit and everyone on this panel, like you get these films maybe a month or 3 months out, and you're like, oh, geez, maybe they're tilted over, and they're asking, hey, how much PT do I need to get back to the middle? And you're just kind of thinking to yourself, man, maybe if I was able to see this a little better, So I think there are all these things that we have. I mean, we all like to fall on the sword, I think, but I think having the tools to really visualize everything, I think is so key.
Yeah.
Very nice job, Johannes. Phil, do you mind transitioning to our next case?
Sure. Yep. Let's see.
We'll try and keep things a little more interesting, not just, T10 to pelvis failure, T10 to pelvis failure. So we have 2 other cases here for you. I think it's nice to highlight and hit some of these high button topics because all of us are obviously curious what each other's practices look like to see if we can steal some pearls for our own. So this is an interesting case of Dr. Kalso's that we'll have Phil presenting.
Yep. Hi, everyone. Philip Johnson, one of the orthopedic spine surgery fellows at UPenn. I'm just going to go over a case of Dr. Kalso's proximal junctional kyphosis and failure. So the case is a 61-year-old male. He's a former smoker, diabetic, morbid obesity, which you can see on the X-ray. He had 3 years of progressive low back pain, difficulty standing upright, fatigue while walking. Were kind of his initial presentation. He had this construct done at our institution, L3 to S1, posterior and LF instrumentation and fusion. Initially did well post-operatively. but then began having these symptoms. So 1 year after this, we see X-rays, AP lateral on the left, and then a supine X-ray on the right, showing proximal junctional kyphosis, approximately 17 degrees. You can see some of that anterior wedging and kind of loss of bone at the upper instrumented vertebra, with significant facet subluxation, with pretty significant reduction. So clearly unstable. But at the time, the patient was actually clinically doing quite well, playing golf, no complaints. So he was followed for another 6 months, and unfortunately, his kyphosis increased from 17 to 28 degrees, as you can see here on the X-rays. And he also began reporting progressive lower extremity weakness. Over the last couple of weeks, he came in a wheelchair and had increased difficulty standing. So I guess a question I was just going to propose before I get to the MRI and what we did is, in terms of, when you go after this, are you waiting, until there's clinical decline, as in, what we did in this case, or as soon as you start to see that PJK, do you sort of jump on it?
Let me ask another old fart question. The original surgery was for stenosis and back pain, correct?
Yes, stenosis, back pain, difficulty standing upright as well initially.
And I've got a small screen on my computer. Is there a spondy at 5'1"?
There's some autofusion going on there. Low grade.
Okay,
Yeah.
so what I'm getting to is, what was the original indication for the fusion, presuming you were treating stenosis?
Yeah, I can touch on this. This was my patient. Yeah, so severe sagittal imbalance, severe stenosis. If you look at his pre-op MRI before this, he had like massive facet cysts that was contributing to his stenosis. So he was unstable at those two segments as well. He always had the autofusion at L5S1. We didn't try to take that down. That was how he was when he presented to us. So, we try to do a less is more here with just a 2-level extension, decompression fusion. We did posterior column osteotomies here as well to try to bring them back in addition to those L lifts. But yes, I agree. A laminectomy would be a great operation, and avoid all this hardware complications. But this guy was unstable going into this.
Yeah. And I guess the second question would be, given the construct as it was, which is what you needed to do with his pendulous belly, is this almost predictable with that kind of paniculus in front? I mean, you can see it's soft tissues on the X-rays. I mean, he's obviously his load is way forward.
So this was we kind of cut out some of the discussion about the decision making for this, just to focus on the PJF portion of this. But this was a guy who had a PIL mismatch of about 30 degrees that we thought 2 levels of real posterior column osteotomies and lordotic L lifts to kind of bring that mismatch down significantly would be kind of the right answer. We got his PIL mismatch in a better range, but I agree with you. This is like the X factor of a pendulous belly and undercorrection of SVA, kind of in a nutshell here. So it's actually, we're starting to look at this population, what role, this pendulous abdomen has in preventing, achievement of a targeted SVA goal. Because I think that's also an important topic here that, we may have corrected his lordosis, but we did not dial him in where he needed to be.
I was going to ask you also, did you try to be careful not to violate posterior elements at the top of the construct? It's hard to see here how much of a laminectomy, but that might set this guy up also with the anterior load to fall into kyphosis. Just looking back on it, do you know what was done initially?
Yeah, so I did Smith-Pete osteotomies at that top segment. I try to preserve the top of the lamina there. But without a doubt, I think Monday morning quarterback here, is probably don't stop your construct at Smith-Peet osteotomies, and probably at least go a segment up above. Because, you know, obviously when you see this degree of failure, you know, it's not that he's overcorrected here. It's probably more, you know, surgical technique.
Yeah, and the other thing to follow up on what Jack said is, you know, obviously we didn't see the pre-op MRIs to see what the extent of stenosis is, but with good interbodies, either anterior or lateral, and potentially perc screws in the back, I mean, is a laminectomy always necessary with stenosis that you could get indirect decompression just from, you know, good anterior column realignment and perc screws? And if you don't do the, you know, a lot of posterior work, might that decrease the chance of a proximal failure?
Yeah, I totally agree. I love L-lifts and perc screws. I think you looked at this guy's pre-op MRI, literally his facet cyst is obliterating his spinal canal.
I mean, obviously,
you know, but I agree with you wholeheartedly.
Yeah, I mean, yeah,
Jack,
I mean,
I
under
think
those
you-
circumstances, you can't avoid going in.
Yeah.
Jack, I think you make a very valuable point, and that oftentimes when we're thinking of these longer constructs, we're not disrupting the top few levels in relation to that posterior soft tissue band, but, you know, doing smaller, quote unquote, what we call degenerative issues, and we'll take down supraspinous, intraspinous ligaments without giving it too much thought. And I agree with you. The idea of tying into that robust ligamentous structure is incredibly important because, again, when we think about creating a big lever arm that's separate from another area, obviously, you know, issues can present themselves. And it's something we think about with deformity, but maybe more so for some other things as well. Phil, do you mind just kind of progressing through?
Yep. So these are his most recent MRIs before the revision. So it showed a very large disc herniation, near complete disc collapse, with a severe central stenosis, even at the level of the conus. CT scan, did show bony fusion L3 to S1 from the previous construct, not shown here. As far as, so these are some intraoperative floor radiographs from left to right. So in order to correct this kyphosis, actually we involved general surgery for assistance with a transos approach where we did an ACR with a ALL resection to be able to get correction, and then placed a hyperlordotic cage a little bit more posteriorly to get maximal correction, and then a temporizing plate laterally. And then here are the postoperative films, AP and lateral, so pretty significant kyphosis correction there at the L2-3 segment, then instrumentation up to T10 with two staggered accessory rods bypassing the previous PJK. And then here are his final standing films with increased lordosis. I believe he started around 40 degrees of lordosis, so we got a little bit more.
So you know, I have a question for some of our panel here. Who would have gone right down to the bottom and done a L5 PSO right off the bat here? Obviously, there I think the 5-1 autofusion and a bit of kyphosis is kind of the primary driver of some of this deformity. You know, and you know, obviously this was an effort to avoid a PSO. But obviously this is a bit of a unique take on a PJF correction, which is why we included it here. But I think there's some broader
This is an interesting case. It's very challenging. I'd love to see the CAT scan. I know it's not a part of the slideshow, but I can't tell exactly what's going on at 5-1, if it's autofused there or a bit kyphotic even. And I think these are challenging. I have a few patients like this, where the 5-1 has incredibly insufficient lordosis, and you have a very difficult time catching up at the upper levels, and you end up chasing your tail for a long time. It seems excessive to kind of go back into a fused or semi-fused 5-1. It's very difficult to do probably there's a laminectomy there. It's a there looks like someone dropped napalm, tried to do a PSO, and that is is very difficult, but I think that's probably the best treatment. I've done the same. I still do the same. You treat what comes your way. It's obvious that level leads a laminectomy. You put an interbody from whichever T-lif, L-lif, anterior, whatever, but it always ends up not being enough somehow.
Yeah, yeah. I think where this guy started, we were trying to quote unquote get away with a 2-level decompression infusion.
Right.
And PSO wasn't in the cards at that point.
That's right. That's right.
Then it's this, this failure episode. You go back, fix this, and do a PSO at 5.
Yeah, it seems too much.
Very, very functional now. I'll tell you, this guy is just tough as nails, but obviously a bit of a unique take here.
It also shows how powerful the technique is when you release the anterior ligament, and I'm a fan of that. I think it's if you don't do that, I find it very challenging to obtain lordosis from a lateral, any meaningful lordosis anyway.
I don't know how much data you have on this, but if the etiology, I mean, if the primary clinical complaints were back pain, and you get that kind of correction above, do you see stretched neuropraxias? Because that's really a distracted level.
A very large cage,
no, I haven't. I've done a couple of these. This is probably the most profound one, I would say, from a one segment correction. But yeah, we're running neuromonitoring, obviously. But it's a bit jarring also from just a vascular stretch injury as well, obviously.
Mm-hmm.
Just a comment from Dr. Chapman. Amr, did you use pelvic fixation on this? Bill, can we go to the final x-rays?
Yeah, so I'll tell you, again, like devil's in the details with this preoperative imaging. He had a robust 5-1 autofusion. So I think we made a decision here that he had a little bit of transitional anatomy. We had 4 fixed screws kind of distal to the lowest mobile segment here. So we chose to bottom out our construct just with bilateral L5, bilateral transitional S1 screws here. And again, big, long, wide screws. I think obviously employing pelvic fixation, I usually have a low threshold for, but I didn't feel we needed to here. And especially at the time of the revision, solid fusion from L3 down. So I don't know how folks feel about that, but in my mind, if there's a solid fusion for several levels caudally, I'll sometimes forego pelvic fixation, if we have good pedicle screws down below.
Yeah, Amr, and I think that's a great, I think this is a tough case, and I think that you really achieved great lordosis by attacking that higher level, which is not easy to do. And I think that you really dove into the fire there, I think, with that ACR and getting that correction. So my hats off to you. I mean, and I think that just to echo what Ali said, I think that, when it's so fused at L5S1, I think you're starting at a tough spot, because if you look at the slope of that sacrum there, right, the slope of that L5S1 disc space, there's something going on there with how he's just aligned at baseline. And I think you've done everything you could to try to restore as much with that proximal sagittal correction. But, one of the things that I've noticed, not so much immediately, but maybe a couple years down the road, is when I've ended the construct without pelvic fixation, is sometimes these patients can get sacral insufficiency fractures that are distal to that, I've noticed. And this can be like 3 to 5 years down the road, and I think just considering like age-related osteopenia and whatnot, I think that the strategy can work well, but I've experienced that myself, where all of a sudden you see these like fractures and really distally in the sacrum, and the screws themselves may look okay, so that's just one thing to kind of think about too, that just throwing it out there.
And just to follow up on what Scott said, because I was concerned also about a nerve, but the other issue is vascular wise. For a big fat guy, he has remarkably clean looking vessels. If this guy had calcified aorta, would that have changed your plan? Because that's a lot of stretch on the vasculature.
Yeah, for sure. I also think the acuity of how this progressed to, in my mind, implies there's a lot of dynamic changes going on there. versus if he'd been rigidly kyphotic for 5 years like this, I would be concerned both neurologically and vascularly. But I used to do these ACRs by myself, and then I had our approach surgeon come help me out with one, and I'm like, why am I ever doing these by myself? Honestly, I mean, the act of taking a scalpel down that anterior retractor, and not having a vascular and access surgeon in the room. I mean, I think my practice has changed, and I don't do as many of these as I used to. But yeah, I think those are great points, Jack. Definitely need to be mindful of this consideration.
I think this is a super instructive case. I mean, the value of establishing the PI-LL mismatch is so well exemplified here. And when we have these lumbosacral transition anatomy patients that have a deviation there, it is so easy to kind of fall into this forward pitched posture if we don't succeed in getting L4 level. And I agree with Dr. Shin. It's so great to have you, by the way, John. Fantastic to have you join here. I would always, for a patient who wants to pitch forwards, advocate for 1 or 2 pelvic screws on either side and have a firm foundation, even if the lumbosacral junction itself is fixed. And sacral insufficiency factors or just increased SI joint arthropathies or the SI joint actually pitching forwards are all things. This guy's always putting an enormous load on his sacrum. So those are just my thoughts, but very instructive case.
Thank you, Jens. Wise words as always, and I agree. The idea behind presenting this is to kind of show a little bit different aspect to some of these problems that present themselves. Poria, do you mind transitioning for our last case?
Absolutely. Let me share my content screen and start broadcast. Okay. All right. Good evening, everyone. I'm Puri Hosseini. I'm one of the orthopedic spine fellows at UPenn. And thanks for the opportunity to present for Seattle Science Foundation. I have used Seattle Science Foundation lectures for many, many years, participated in their courses, and I always learn a lot from your lectures. Thank you very much. So the case that I'm presenting is one of Dr. Casper's cases. And basically is a 77 years old gentleman presenting for the evaluation of the persistent chin on chest deformity. And the patient had in 2023 outside hospital C3 to C7 cervical fusion. And then it came to our clinic with the chin to chest deformity. At the time of the presentation to us, the patient didn't have any baseline preoperative upper extremity weaknesses, but had some preoperative right upper extremity radiculopathy with that deformity. Patient went through robust, extensive physical therapy for the treatment of that possible, correction of that chin to chest and strengthening the posterior musculature of the cervical spine with not much, help and effects. Did not have any injections, and past medical history of the patient for completion included diabetes, CKD stage 3, cardiac stenting, and the patient was on Plavix and aspirin, and also the patient had some skin problems, actinic keratosis. Physical examination of the patient. The patient had a BMI of 27.3, gait, no antalgic reciprocal gait without assistive devices. The skin was well healed, the surgical site was well healed, and also a very obvious clinical chin to chest deformity. Patient, when attempted for the extension of this neck, had some paraspinal muscle pain. And neurologically, patient was intact. On the x-rays, as you see on the right side,
had that deformity, obviously, even on the x-rays, very obvious. At the bottom corner, if I could zoom it in, it shows some haloing around the C7 screws. And I measured that T1 slope of 56 degrees.
Corey, just in
So
the interest of time here, I'm going to interrupt you, and I'd like to hear, Jens, if you don't mind commenting, Jack, Scott. I think the problem with this was obviously there was a decompression done down through C7, and they stopped with lateral mass screws at C7. Just broad strokes, if you're doing a posterior cervical decompression infusion, and we can argue about the merits in someone that has well-preserved anatomy, but where are you stopping your laminectomy, and how many points of fixation do you want below that, and what types of screws are you aiming for?
So I'll take a lead. This is obviously an almost predictable failure point. I would always want to go down to T1 or T2 for inflammatory patients, and again, large core pedicle screws that are well placed with nearby cortical purchase would be my preference. Any other thoughts?
Well, the other is just the soft tissue envelope, whether they did a good enough closure, whether the extensor mechanism rolled down, and it's got like a boutonniere deformity and a rheumatoid where the extensor tendons are now volar to the joint, so it kind of pulls them into flexion. So that's the other factor here. It may be more than just bony disease. It may be that the musculofascial envelope was also disrupted.
Well, and certainly with the technology now of navigation, there's really no excuse to do, weak lateral mass fixation when you can do very accurate pedicle fixation, like Jens said, and then get down a couple levels to augment that, utilizing technology.
I think all those points are totally spot on. Again, the soft tissue closure on this was probably not the best, and we noticed that when we went in for the revision surgery. Again, posterior soft tissue tension band was taken down to T1. They ended with 12 millimeter lateral mass screws. So, I think the writing was on the wall after the surgery was done. Maybe John or Ali, comments on kind of the x-rays and your thought process as to flexibility or ways in which you're setting up for this, or how you're going in. I think Ali, you kind of hit the nail on the head. You're going in with, the potential to do a pretty big operation, but determining how flexible they are.
Yeah, I mean, for this, if it's a cervical kyphosis, I definitely do some flexion extension, see what the patient would give me. I wouldn't expect to have to do 3-column work here, and I think you're going to get everything you need with posterior column osteotomies at most.
Yeah, I also find it helpful to get supine x-rays. I like to get them. Sometimes a lot of times we're getting CT scans before we're anticipating doing these like corrections, and you can see that on a scout too. I like to really see that, and sometimes I even tell the family members, hey, I want this guy to lie down, take away the pillows,
Yeah, that's
and
right.
just take a couple pictures for me and send me the pictures, and I'll put that into Epic, and so you see like, hey, this guy actually, or person can actually sort of neutralize a little bit. It gives me some idea of the flexibility, but I think that's hard. I think it's, with the exception of ink spawn cases, I think it's really tough for us to really determine the flexibility of these curves, So I think more often than not, they tend to be somewhat flexible.
And Dave, this happened kind of in, less than a year, so I wouldn't expect anything too rigid here. But who knows? You're always can be humble.
I agree with you. And oftentimes they do engage and shorten their anterior chest muscles. I agree. I like having them lie down on the table in the clinic, and actually have them hang their head over the side of the table and just kind of wane a little bit to see if they fatigue those muscles, and see where their head drops back to kind of gauge a little bit of flexibility. Or do you mind moving forward just in the interest of time?
Absolutely. So as you see on the CT scan, there are some haloids around that C7 screws. And so, yeah, the patient went for the revision surgery, and we extended the fixation from the C2 to T4 with the third rod from the C2 to T3. There are laminar screws on that C2 and T3 and T2 and T3 for that extra rod for augmentation. And so that is immediate post-operative image. And obviously, the screw sizes were upsized and as revised. And this is the 5 months post-operative image on the left side that the patient's chin and chest deformity has corrected, and the patient so far is doing okay.
That's a great result. And I really like the use of the subaxial cervical pedicle screws. I think, Dave, you have there at C6, it looks like. I think that's a really great point of fixation, but that's a tremendous job. Great job.
Yeah, I bet, and I'd be curious to get thoughts. I find, that C2 translam screw is a different vector of pullout than whether it's C2 or pedicle or par screws. So really for his head to fall forward again, he's got to really rip that C2 spinous process off. And, as a bigger guy, I think we did get lucky in the sense that he was quite flexible. This wasn't, overtly difficult to reduce by any stretch. And I think that saved us pretty significantly. Anyone employed the use of, a hard collar CTO, any other things might introduce to help this guy along?
Yeah, I'll usually use a CTO for these kind of longer cervical thoracic constructs. I know there's not really data behind it, but probably more for me than for the patient.
Dave, I'm a fan of CTOs here as well, and it's not the part that you treated that I'm trying to protect. It's the junction, So wherever I stop, I'll try to protect that with some external orthosis for a couple
How
months.
long?
Couple months, just
Oh,
until
okay.
some scarring, occurs and yeah.
Sure. And what's your biological choice for osseous fusion?
It's a good question for this. I will use local autographs that I take in the areas and really just try and burr out those facets, and then I'll supplement it with some crushed cancellas.
I use BMP for all of
Yeah,
this.
I've used it here too.
Yeah, I use BMP as well. And I think the point raised earlier about bracing, I often struggle with how do you rehabilitate these, shoulder muscle, the shoulders and the extensor muscles after such an operation, because we retract so much, and especially in the upper thoracic spine. And I think this X-ray on the left is really great because it just shows how much like that patient is trying to stand upright and maintain horizontal gaze. But I've seen in my practice over the years how when I see them at 3 months, 6 months, a year, that SVA starts to creep a little bit. That angle between the occiput and C2 also opens up quite a bit. And so even though the screws may look great, there's something about the musculature and the ligamented taxis that I think kind of fights against the correction that you work so hard for. So I'm curious if anyone has any good pointers on like when to aggressively start rehabbing that after bracing.
Yeah, I'm very curious. We have maybe 1 minute. I'm very curious also. I've been waiting longer and longer to start PT after these, 2 months, sometimes longer. I think we mobilize patients way too soon after a big spine operation. That includes in the hospital, and I know it's for good reason. I know, clots and pneumonias and this and that, but I find patients who go through a big deformity operation, if they have a period of prolonged bed rest that was unanticipated, I wish I could write this up, but I'm convinced they do better. If they just end up in bed for a week or so, they do much better, in my opinion.
Rush Fisher asked if there's any dysphagia or swallowing problems after you bring somebody up to this degree. This guy do
Jack, I
okay?
think it's a great point. If they're chronic and they've been like this for years, I definitely worry about that significantly. This guy was pretty passively corrective in the office and had a lot of concern with that. But kind of those kyphotic necks that you do a lot of anterior work and then posterior, certainly something of concern. So again, I really appreciate the time, and obviously, thank you to Dr. Ozturk, Dr. Shin, Dr. Kalsa, our fellows. We really enjoy each of the times that we get to present and show off some of our unique work. So certainly looking forward to it the next time, Jack, Jens, Scott, we really appreciate you guys and your words of wisdom.
And thank you, UPenn. Fantastic program, really cool cases, difficult cases, great learning opportunities. And Dr. Ziegler, Dr. Blumenthal, do you want to make a little announcement about next week?
I was hoping Dr. Chapman would make the commercial, but if you haven't had enough of Dr. Blumenthal, Dr. Chapman, and myself, next weekend will be our 6th annual motion preservation course. It'll be Friday evening and Saturday, and we'll have a pretty big virtual audience. Well, you know, some people there in person, but we'll do the usual, some debates, some case presentations, cadaver lab, several sessions, doing side-by-side tips and tricks. So it's always a pretty fun course, and having Jens as the MC always makes it special. So I hope you can join us and get your CMEs for today. And thank you again, UPenn guys. It's just a pleasure.
A great job, and thank you guys.
Thanks,
Stay,
Dave. Thank you. Have a great
stay
night.
well, everybody.
Thanks, everyone.
Bye-bye.
Yeah.